The next component of your thoracic wall is the some of your important joints related to the vertebrae, or some joints related here even to the sternum, because ribs are connected here. We are making joints posteriorly with the vertebral column at the different places here, like in the body with the transverse process. They are making various joints, and they have obviously some important ligaments here, and some of the ligaments are those which are connecting the vertebrae with each other also. So, we will discuss and see some of them. And similarly, anteriorly we have the ribs which are having a joint with the costal cartilages, and the costal cartilages themselves are having the joints with the sternum, and even the sternum has the 3 components, and they are also having a joints with each other. Anatomy in brief of all these structures you are required to do also. Now, you see in this structure, first thing, because we have already told you that the sternum basically has having 3 parts here. One is called manubrium sterni. Menu means handle, hand, this is the handle of the sternum. Then another is the body of sternum. And third is the xiphoid process. So, we have 3 parts of the sternum. Sternum already we have discussed. This is called the breastbone also, and it is forming the anterior and middle part of your thoracic cage. So, see here in this especially a joint has been created. This is called a manubro-sternal joint. You watch here this. So, we have seen this one. This is called the manubrum sterni. This is a suprasternal notch. You are watching here this another facet for the clavicle to accommodate and forming a sternoclavicular joint, clavicular notch. Then is the first costal cartilage is attached here. So, costal notch is there on this side, and similarly on the other side also, and here. So, that means this manubrum sterni, if manubrum sterni inferiorly it has the articular facet, and that articular facet will have a corresponding facet here on the upper part of the body of the sternum, and it will forming here a joint. This joint is called manubro-sternal joint. All the joints usually are supposed to be in the midline if they are anteriorly or posteriorly, they are called secondary cartilaginous joints. Secondary cartilaginous joint, if for example, if you remember, secondary cartilage means so the bone is coming from one side, as the bone is coming from other side, and if it has a cartilage, that is the hyaline cartilage in the middle, you will call such joints as the primary cartilaginous joints. A very good example is the costochondral junction, or another example is in the young bones is the epiphyseal plate. Epiphysis on one side and a diaphysis on the other side, connected by means of the epiphyseal plate, a joint. This is a primary cartilaginous joint. Such joints are called the synchondrosis. But here in this case, if for example, this hyaline cartilage which we are showing you here, if this hyaline cartilage, most of the portion in the middle gets fibrosed, it is converted into fibrous, this secondary change is happening. If it happens like this green color is a fibrous tissue. So, most of the hyaline cartilage has become transformed into the fibrous tissue, and remaining portion which could not be converted into fibrous tissue will remain the hyaline cartilage. Means hyaline cartilage will be lining the articular surfaces still, because there is a secondary change. That is why this joint will not be called as the primary cartilaginous, but we will call it the secondary cartilaginous joints. And these are actually nickname of these types of joints. They have got a specific term for them. This is called the symphysis. So, symphysis is the other name of the secondary cartilaginous joints. Almost all of these joints, literally all of these joints, they lie in the midline either anteriorly or posteriorly, but not see all joints lying in the midline anteriorly, they are symphysis. But if there is symphysis, it must be lying in the midline. Like for example, you have 2 mandibles, 2 halves of the mandibles, if they are joining here in the middle, this is sometimes called even symphysis menta, mental symphysis, but this is not a symphysis. Actually, this is not a joint altogether, because this is mandible's two halves are there, in the middle we do not have any joint here. But after this chin, if you see after this symphysis menta, if you come down here, you see mandibular sternum, and now you are having a joint here. This joint is very much, yes, it is symphysis. So this sometimes it called the secondary cartilage in the joint, we call the mandibulosternal symphysis, even you do not call it a joint sometimes. And here this mandibulosternal joint means it is say mandiburum and is the body of the sternum. So this joint which I was actually telling you, it is called a mandibulosternal joint. This is secondary cartilaginous joint. And there is also little bit of movement, and movement is on the longitudinal axis, say between the two parts of the sternum, between mandibular sternum and here during inspiration. So it will have little bit, you see that it is having angular movement here, like this here, convexity on the back side, you see. Less than, you see, less than 7° angulation it will be created here. That will increase obviously when it is angulated here, you can say it was straight initially the vertebral column, but when it gets angulated, for example, you see this angulated here, like here it gets angulated here. So your anterior posterior diameter increases, and when the anterior posterior diameter increases temporarily, inside the pressure will be less and outside the pressure is constant. So from outside in, the air will rush in. So this will actually help in inspiration, facilitating the act of inspiration. But the total range of movement is not too much movement is not too much movement here. Total range of movement is less than even approximately 7 degrees. This is called the mandibulosternal joint, very important joint here, in a sense that is anatomically is the big landmark here, because this is the mandibulosternal joint, this is called the sternal angle also, and we have already told you that this joint where is attached to your second costal cartilage. Second costal cartilage, if the mandibular sternum and the body of the sternum, here the second costal cartilage, because second costal cartilage has two facets, half will be accommodated by the lower part of the mandibular sternum, and another demifacet, the lower demifacet will be accommodated by the uppermost part of the body of the sternum. So second rib can be second costal cartilage, and surely the second rib can be failed here, it can be palpated. That is why the ribs are counted from this, because when you are actually feeling this jugular notch and we are passing your hand below here at the jugular notch, for example, you are passing here feeling your jugular notch and you are passing your hand on the say fingers on your anterior surface of your mandibular sternum, immediately there is mandibular sternal joint will come, and here will be a transverse ridge will be felt here. If the transverse ridge will be felt here, you will say that mandibular sternal joint has come, and here laterally it will be two costal cartilages, one each. This is the second costal cartilage, and surely here will be the rib. If the second rib has been felt here, so above the second will be the first intercostal space, below will be the second, and then will be the ribs will be counted easily here. And this I told you that if the mandibular sternum, here is the mandibular sternum, and here will be your so mandibular sternum, you see here, and then this is a body of sternum. So here will be your mandibular sternal joint here, and because there is some angulation here, that is why it is called sternal angle also, or the angle of Lewis, and it is important from many points of view. See that. Then after the body of sternum, you will actually look at another joint, that is called the xiphisternal joint. This is the joint between xiphoid process and the end of the sternum here. This is xiphisternal joint. Xiphisternal joint, though it is lying in the midline, but the xiphisternal joint is not a secondary cartilaginous or a symphysis. This is a primary cartilaginous joint. That is why I call them synchondrosis. So much so that sometimes it is called the xiphisternal synchondrosis, like a mandibulosternal symphysis, but here is xiphisternal synchondrosis. This remains until the middle years of the life, but usually it ossifies here. Here is the cartilage, but later it will ossify, it gets fused with the rest of the sternum here. Though no more joint here. And here xiphisternal joint, if you see this here, if for example you are looking at this, in front for example is anterior posteriorly, I am showing you here. See, if you are actually looking, okay, if you are watching here like this is your mandibular sternum, then another part, this is called body of sternum, and the last part is called the Ziegfeld process. Now, if you are actually looking at this Ziegfeld process or where the Ziegfeld joint is present, behind this, if you draw here line, behind the Ziegfeld joint is lying your ninth thoracic vertebra, and behind your mandibular sterna and the sternum is called the mandibular sternal joint, or behind the sternal angle, if you draw a line here, imaginary line, behind will be lying here fourth thoracic vertebra, means lower border of the fourth, or you can say intervertebral disc between 4 and 5, and here the intervertebral disc between 9 and 10, means here is 5, here is 9. So, here will be behind the body of sternum will be 6, 7, 8, and above that will be, you see that above it is 4, and behind here means here is suprasternal arch. If you are actually drawing here horizontal line, so here will be 3, 2 and 1, they will be above. This is T1, this is T2, and below here will be 2 more, that is called 11, and this is called 12. So, you are actually watching here, this is suprasternal notch and this is the T1 vertebra's upper border here. So, this will be, if you are drawing the line here, this will make here the entrance into your thoracic cavity. This is called the thoracic inlet, and here you stop because your diaphragm comes from here. So, this diaphragm is a dome like, so it will be like this here, and below is the abdomen. So, if the liver is protected here under the diaphragm, so this will be under the ribs. That is why when the ribs fracture, liver gets the injury, and here is your various important levels of the vertebrae along with, you see, in relation to your sternum anteriorly. So, Ziegfeld joint lies behind the Ziegfeld joint is lying the 9th thoracic vertebra, or this imaginary line will pass through the intervertebral disc between 9 and 10. Similarly, here sternal angle, its line passes here through the intervertebral disc between T4 and T5. Ziegfeld process, already we have told you that it is pointed here. It sometimes can be blunt even sometimes can be even bifid also, or even be curved sometimes, or it can be even deflected one way or the other. And I have already told you that it is cartilaginous in the middle, say in the young age, but after 40 it gets ossified here, it will become a part of the sternum, does not have any joint in between, just like a epiphyseal plate. See the Ziegfeld joint here. Then you see some other joints here, costochondral, costo means rib, costa means ribs, chondral means the cartilage. The joint between the ribs and the costal cartilages, you watch it here. Between each rib you will see that between each rib and its costal cartilage. If you are seeing the rib here, then there is a costal cartilage. So, this green colors points which we are showing you here, these are the costochondral joints here. These are the primary cartilaginous joint, because here is the bone, rib is the bone, sternum is the bone, in between there is a hyaline cartilage. A very good example of primary cartilaginous joints. And such, and when there is a primary cartilaginous joints, hyaline cartilage must be intervening, and this hyaline cartilage sooner or later will get ossified also, because these costal cartilage will not remain here. After 40 years you will see that they get ossified, and then the ribs will have less movements now and they become very rigid. Now, if you are able to look at them, it is very important fact about them is, if for example you are watching here your rib, and I already told you that from the costal side they have got the cup like ending here, and then is your costal cartilage, and the costal cartilage, then the then the sternum or mandibular sterna comes. Now, your rib is covered with a periosteum, and costal cartilage is covered with the perichondrium. The pericardium and the periosteum, they are continuous with each other here. This is important thing here in this. And because this is a primary cartilaginous joint, so usually they allow no movement. So, between the rib and the costal cartilage, between the rib here and the costal cartilage, there is no movement here. So, costochondral joints, they are important here, and we have already told you that the first costal cartilage is attached here to the costal groove or the costal notch at the superior lateral angle of the manubrium sterni. The second as the two demifacets, so half is attached here to the manubrium sterni and half attached to the sternum. Then the third also, the fourth, the fifth, the sixth and seventh, and seventh are attached here to the xiphisternal joint, half to the sternum lower end and half to the xiphoid process. And then after that, this is something true about the true ribs, and after that, if your 8th, 9th and 10th ribs comes, they do not reach the sternum directly, they reach via their costal cartilage, which is attached here to the costal cartilage above them, and the last two ribs, they do not reach directly and indirectly, they do not reach to the sternum at all. These are called the floating ribs. Costochondral joints, already we have told you the costochondral, about which already this is the rib which you have already seen, and these ribs basically they are spongy, interior, their interior is spongy, means outside they have got the periosteum, underlying there will be the compact bone, inside they will have the periosteum, underlying will be the compact bone, but in between it is a spongy structure. Important, why? Because this will give rise here to the hematopoietic tissue which forms the blood cells. So, important is the costochondral joints. Costal cartilages, already we have told you. Costal cartilages of the first 8 ribs, they increase in size, you see, from above downward. You see this is first small, it is a little larger, still larger, more large, larger, larger, larger. They gets larger and larger from above downward. First 7 costal cartilages, we have already told you, they are directly attached and the remaining indirectly. The costochondral joints, they are important. Then is interchondral, chondrochondral. Interchondral means you see here, between the 6th and the 7th, between 7th and 8th, then between 8th and 9th, these are the chondrochondral. You see that is attached here. This is 7th. So, this is 8th with the 7th, and such joints you have already watched here. These are the interchondral joints. They are also the plain synovial type of joints here. And interchondral ligaments are there which will strengthen them, and they have got the synovial even cavities, and they have their capsules also. So, these are not they are fused, you can say, they are not fused as such, you say, they have the joint here. These are interchondral joints, they have the interchondral, these are the interchondral joints. Then if you actually look at here, we have some other like sternocostal joint. Sternocostal means the costal cartilage is this time attached to the side of the sternum here. Sternocostal, or you say sterno and costal. Costal means not the rib, but the costal cartilage. That is why you can call them precisely sternochondral joint. This is sternocondral joint. How many? You have already seen manubrium sterni. It is costal notch, the first costal cartilage was attached, and the second was attached to the manubriosternal joint at the sternal angle. So, they are attached here to the lateral borders here. They are also synovial type of joints. The costal cartilages, already we have seen how many of them there will be such joints here, from 1 to 7 they will be, because from 8, 9 and 10 they are chondrochondral. And the last 2 ribs, they do not have any joints here with the sternum. So, you see these joints also important from this point of view. And we have already seen the first pair of costal cartilage articulates with the manubrium by means of a thin fibrocartilage interposed between them. The first costal cartilage, especially the first costal cartilage, this is very important. First costal cartilage has actually the cartilage in between with the first costal cartilage and the medium sterni, and this is the synchondrosis. This is not synovial, this is synchondrosis, first costal cartilage. First sternocostal joint, it is synchondrosis, remaining all others are synovial type of it. Second to seventh costal cartilage is articular with the sternum at the synovial joints, with the fibrocartilaginous articular surfaces on both sides. But they are not typical because there is not hyaline cartilage in between, but we have got the fibrocartilaginous articular surfaces on both sides, from the condyle side as well as from the sternal side. They allow the movements also. So, here we have here the fibrocartilage. We have synovial joint, but they are atypical synovial joint. But the first one is not a synovial joint, that is the synchondrosis. This is important, this is usually asked in the exam. These are some joints which are about the ribs anteriorly with the sternum, but you see the ribs posteriorly with the vertebral column. Costovertebral joint. Costovertebral means with the costa, means ribs with the vertebral column, with the vertebrae. Costovertebral joints, again these are synovial type of joints surrounded by the capsule. And these joints, if you see, look at this, for example, if this is the rib here, so rib will have the head, so rib will have the head here, and if the head has the two demifacets, one demifacet, it will be accommodated here by the upper articular surface, upper articular facet, upper costal facet here, and smaller demifacets will be accommodated by the costal facets at the preceding rib here. If for example, this is the fourth rib, so this is fourth vertebra and this will be the third vertebra. So, it is actually getting the share from both, but a much larger share it derives from its own corresponding vertebra and less from its neighbor. Neighbor means the preceding, not the following. See, these joints are again very important, and we see these most of the ribs which are forming these joints is called the costovertebral joints, and most of the ribs you see they are attached with the intervertebral discs also. They are attached to the intervertebral disc by intra-articular, because here is the capsule. So, inside the capsule they have even inside the capsule they have ligaments, and these ligaments will attach them to the sides of the intervertebral discs here. The costovertebral joint is not simply costovertebral, but they are attached here to the intervertebral disc also through the intra-articular ligaments. Costovertebral joint. Again, this is costovertebral. And costovertebral joint, it has lot of you see ligaments which are in fact supporting them. Even some ligaments which are accessory, they are not related to the costovertebral, but here they are related here to the transverse processes and to the ribs here, costotransverse joints. You see there are costotransverse joints, are some even between the transverse processes, these are called the intertransverse joints, intertransverse ligaments. So, these ligaments are some accessory ligaments, they are not related directly to them, but they stabilize them. These are called the costovertebral. You watch this also is costovertebral. You will see here the facet attaching here. Costovertebral joint. See head with the costal facet on the body. Then is the costotransverse joint. Costotransverse joint is this one. You see again. This is where we watch here this transverse process. At the tip of the transverse process, there is a notch. There is a facet. There is a facet in the tip of the transverse process of the vertebra, thoracic vertebra. A characteristic feature of any thoracic vertebra is this. You can identify a thoracic vertebra by just looking at the tip of the transverse process of any thoracic vertebra. If it is having a facet for articulation of the tubercle of the rib here, to form the costotransverse joint, you will call this is the thoracic vertebra. This cannot be any other vertebra except thoracic when it has its transverse process having a facet here. All the 12 thoracic vertebrae, they have their transverse processes bearing facets for the tubercle of here, except the, you see, last two, you say 11th and 12th, they will not have. So, costal facets you are already watching here. Again you are seeing this tubercle of the rib, making here a joint with the facet in the tip of the transverse process to form here a costotransverse joint. And costotransverse joint is, you see again, and here is the ligament which is called the costotransverse ligament. Again superior costotransverse ligaments are also there. You see here the rib, this rib is having a tubercle here, you see this is superior costotransverse. You are watching intertransverse also, this is intertransverse between the transverse processes, stabilizing the joint here, intertransverse joints. This is costotransverse ligament, it is costotransverse joint which has been shown you again here, this one. And you have seen here, this is also lateral costotransverse ligament. We have got this costotransverse ligament. We have the superior costotransverse ligament also, you have seen previously here, superior and then we have got intertransverse ligament, this is superior costotransverse ligament. So, they are stabilizing the costotransverse joint. Again a synovial type of a joint, small rotatory movements are present here at the time of inspiration and expiration. You see that the ribs move inside them, the tubercle moves inside them. These are the costal facets in the tips of the transverse processes. Then you watch here the intervertebral discs, again a kind of a joint. So, here you are watching here the vertebra. So, vertebra is there, another vertebra, and that vertebra, their articular surfaces are covered with the hyaline cartilage, but in between the space which is present, in between which space is present, it is a fibrous. So, again the one which you are showing here, hyaline fibrous secondary cartilage joints, good example, symphysis, because it is in the midline also. So, intervertebral disc is a good example of symphysis. A disc forms a fibrocartilaginous joints are the symphysis, they allow slight movements here, and ligaments all around them, they will hold them. And if you actually look at here, this is a intervertebral disc which you are actually seeing here. Collectively the discs make up of the whole total if you are seeing. So, if you see here the entire spine, if you are actually counting here, and if you are measuring the entire spine, almost 1/3 of your total length of your vertebral column is made up of these discs. And we have totally 30 vertebrae, but we have in all 23 discs. In such a way that if you have for example, if you have here the skull and we have got the first cervical vertebra, in between we do not have, but below that we start 23 discs. 6 we have 7 cervical vertebrae, but we have 7 cervical discs. We have 12 thoracic, we have 5 lumbar, but the sacrum, because it is a single piece, we do not have any intervertebral disc between. So, 12, 6, 18, 5, 23, total 23 discs we have. And if you look at the disc now, for example, if you look at this disc, half have been cut here, but if you look at this disc, it looks like here. For example, if you are looking at this disc, it will have a central core here, which is gelatinous, this one. If you look at the disc in the central portion, this is having here a core or a nucleus, that nucleus is gelatinous. This is a derivative of the notochord. This embryonic derivation of this is notochord here. So, this is called the nucleus. We call this gelatinous nucleus as the nucleus pulposus, pulp like, gelatinous. But the one around that, this tissue which is around them, this one, this is fibrous. See this here, this is fibrous. This is called this one, this fibrous which is actually around that, this one, or you can say this one, this is fibrous. This fibrous which is actually around there, this is called a annulus, because it is rounded ring like, annulus fibrosus. But the central one, this is called a nucleus pulposus. This is nucleus pulposus. This is called intervertebral disc. So, nucleus pulposus and then annulus fibrosus together is called, but the nucleus pulposus is the derivative of the notochord, and this is the disc which is in between the bodies of the corresponding vertebrae or the bodies of the adjacent vertebrae. You see this. You see here one disc, another disc, and I told you that total length of your vertebral column almost 1/3 is occupied by this, or you can say 1/4 also. Then another joint, this is called the zygapophyseal joint, zygapophyseal. If you vertebra you have already done, vertebra has got you see vertebra have the two important portions of vertebra, each vertebra can be, one is the body anteriorly placed, and remaining which is actually behind it is called the vertebral arch or the neural arch also, and both are connected by means of the pedicles. These are called the pedicles that you have done in the thoracic vertebra structure. So, this is called the pedicle here, but once you see if vertebra to vertebra we have the joint also, this is called the intervertebral disc, but the lamina of the two vertebrae, adjacent vertebrae, they are also connected, because you see in the lamina this is present. You see, for example, we are looking at this lamina has the upper articular surface, upper articular process, and has the lower articular process also. If the upper articular process of the vertebra, that will make a joint with the lower articular process of your preceding vertebra, and the lower articular process of your vertebra will make a joint with the upper articular process of the following vertebra. These are called the zygapophyseal joints here. Zygapophysis are called, these articular processes name is the zygapophysis. So, if these are present here, you can say two joints on level between, for example, third to fourth vertebra, two joints here also, and the two joints will be between the fourth and the fifth. So, these four joints, and surely this joint also in the center with the bodies also. So, neural arch, or you say vertebral arch, they have got these four joints, and this one which you are actually watching is also having a joint here. So, vertebral column will be stabilized here, and surely there will be certain ligaments which will stabilize them more. Out of this laminae, they are connected here, you can see this here, this is the lamina and this is the lamina also. This lamina are connected here, you see this lamina is connected here. This lamina is connected, and similarly if this lamina is connected also, means upper part of the lamina with the lower part of the preceding lamina, and similarly lower border of this lamina will be connected with the upper border of the following lamina. This ligament is very important to stabilize this. This is called the ligamentum flavum. It is not only this, but from two sides these ligamentum flava, they will in fact join here at the midline also. In such a way, it fits here. You can see here in front will be having a bone, and behind you have you have lamina, but because there is a gap, so this gap will be filled here. So, inside a canal, that is called the vertebral canal, it will be partly bony and partly it will be ligamentous, because ligamentous means the gaps between the lamina of the two adjacent vertebrae, it will be filled by a ligament. This is called the ligamentum flavum. So, vertebral canal is partly bony and partly cartilaginous, you can say, partly ligamentous. This is ligament which you are watching here. Another is more stabilizing them. The adjoining spinous processes, these are spinous processes. They basically it is not thoracic, this is lumbar, but you see there is spinous processes. They are united by means of this weak almost membranous interspinous ligaments between the tips of and in the lower borders of the spines. This will be. These are called interspinous ligaments. This is interspinous ligament. Even the tips of tips of the adjacent spinous process, they are also connected by means of supraspinous ligament. Is coming now. This is called the supraspinous also. So this is supraspinous. Watch it here. It is in continuity. So tip of the one to the tip of others, and then also. So it will be actually like a belt, reaches up to the skull. Not only this, but the body is very tough. You see, this is called, it connects the anterolateral aspects, and not just anterior, but the lateral also aspects of the bodies of the vertebrae, like a belt, and not just here, but the intervertebral disc will also be having wrapped up by them. It extends from where? It extends here, right from your first cervical vertebra down up to the sacrum. So this whole long belt of the ligament is called. It's called the anterior longitudinal ligament here. This is the only ligament that will limit the extension here, because if it is anterior here, so you cannot actually go posteriorly. It means you cannot extend your trunk too much here. That means overextension will be. This is the only ligament that will protect the overextension. This anterior, you are watching this also anterior, but inside, which is actually binding the inner aspect of your bodies of your vertebrae. This is posterior longitudinal ligament, because it is lying inside the, see this is lying inside, you see this is ligamentum filebum. So this is lying inside the vertebral canal. This is posterior, which you have seen from inside, it is looking there. So this, so like a belt, it is continues, and surely it continues from C2, second cervical vertebra downward, it continues up to the sacrum. Means entire vertebral canal, even the sacral canal, because the continuation of the vertebral canal is in the sacrum, is called not the intervertebral canal, there you call them sacral canal. So this will be actually like a belt, it will continue like here. So intervertebral discs will also be attached to them to give them stability. So your intervertebral disc, this joint is, in fact these joints are stabilized by anterior as well as posterior, means anterior here will be, anteriorly it will be here. So you saw here is anterior, you saw here is posterior, binding them together. So intervertebral discs themselves, they are not as stable are they as they are stabilized hereby, means extra stability is provided by the longitudinal ligaments here. And this posterior ligament, when it is undergoing some injury or anything, it has got a lot of pain receptors, and it will be too much painful, and you know that is lying on the posterior aspect of your vertebral bodies. So this will prevent hyperflexion. You see posterior longitudinal hyperflexion, means you cannot bend anteriorly too much, because it will stop you. You see, you cannot actually bend, means if it is here, you cannot bend too anteriorly, because this will stop you. You see anterior longitudinal, and here green color is the posterior longitudinal. And some other joints already, ligaments already we have to, this is a supraspinous, this is interspinous, and you are watching here intertransverse, stabilizing them. Now after this, you have to have here some idea about these are the levels which already I have told you. Now at the end of this lecture, or in this presentation, we want to have a few words about the thoracic inlet and thoracic outlet, because you have already formed the thoracic cage in such a way that posteriorly you have seen the 12 thoracic vertebrae. See, this is a sagittal section, left and right halves have been cut here. So one half is being shown here, this is the right half. So, posteriorly we are having 12 thoracic vertebrae, and you have seen the structure of the vertebra, intervertebral disc, various parts and landmarks in the vertebrae, various joints, their ligaments, you have seen them. Anteriorly we have got here a sternum, its 3 parts we have seen, and their joints also, mandibular-sternal joint and the xiphisternal joint. Posteriorly you have seen them, and from sides you see the ribs have been made here. I am showing you the ribs like here, like this. So, ribs have been made from 2 sides here. A cage has been created. This is called the thoracic cage. Now, in this cage, inside a cavity has been generated, that is called the thoracic cavity, which will be bounded below by, I say, will be limited below by the diaphragm, which will separate it from the abdominal cavity, and will be bounded above by the suprapleural membranes, which will separate them, though incompletely, from the root of the neck. So, there must be bony boundaries which will guide you upward into the neck, or from downward from neck into the thorax. That boundary is actually kind of an aperture, a hole bounded here from all sides by the bone. This is called a thoracic inlet. And when you will actually put your hand through thoracic inlet from your root of the neck, you are in the thoracic cavity until a bony aperture will come, which will be bounded from all sides by the bones available there, from where you will enter into the abdomen, though it is not open as such, because it is bounded here or limited here by the diaphragm. So, you have this thoracic outlet, you can call it. So, this is a thoracic outlet. Now, if you are actually watching in this area, see the diaphragm, how this diaphragm appears. Now, diaphragm will take origin from the bone which is available there, and from here you see we have got the diaphragm. We have for example, this is L1 vertebra, this is L2. So, diaphragm takes origin from even L1, L2, and makes here you see it makes here a dome like here structure, and then is also taking attachment from the back of the xiphoid process and also from the ribs all around. So, we will call this as the diaphragm here. If this is diaphragm limited, and here down will be your abdominal cavity, and above you are actually watching, if this is superior border, you see, if the superior border is the jugular notch or the suprasternal notch, if you draw a horizontal line, imaginary line, that will pass through the disc between 2 and 3, means the first second thoracic vertebra and first thoracic vertebra will be above that horizontal line. And if you are making here horizontal plane that passes through the mandibulo-sternal joint, it will pass through the disc between 4 and 5. So, that means behind your mandibular sterna is lying your 3rd and 4th thoracic vertebrae, and then will be 5th, 6th, 7th and 8th, until you will reach here the imaginary line that passes through the xiphisternal joint, and that will pass between the 9 and 10. So, that means in between these 2 lines we have the 5th, the 6th, the 7th and 8th, and surely it will be 9th also. And we have now 10th, 11th and 12th, they will be below that, and 2nd and here they will, because sternum is not as longer as the 12 thoracic vertebrae, or this thoracic part of the spine can be. So, this upper part, suprasternal notch, and the upper border of T1, because above will be the cervical vertebra, 7th cervical. So, this is here. So, this line you will draw, that will be obliquely coming downward and forward. He says coming down here like this, and here is the hole, because above is lying here the root of the neck. Means this is now called the thoracic inlet, and down here will be the thoracic outlet here, and we will show you this how this happens. Now, see, this is here, if you are actually seeing from above, from the neck, if you are looking at. So, this is the upper border of the T1 vertebra. Your rib, first rib's inner border starts. Similarly, on the other side also. and this will have the manubrium sterna. You already know there is a costal facet on it also. This is the upper border of the manubrium sterna. So, this red color opening which I am showing you here, through this you can enter into the thoracic cavity. This is called thoracic inlet. And the structures which are in fact will coming out of, for example, if the artery comes out of it, it will come first in the root of the neck and can travel into the neck here. For example, if I am showing you the neck like here, so it can travel into the neck here and will go to the neck, face and brain. Or if the artery comes out of this thorax through the thoracic inlet, can come into the root of the neck, surely will come into the root of the neck, but it will not continue into the neck, goes laterally above the first rib to enter here into the upper limb. This is a subclavian artery that will become axillary artery. I mean, this is another way through which your structures will come, and same as the veins also. Veins come from the root of the neck and will go to the thoracic cavity through this thoracic inlet, or will come from the upper limb and jump over the first rib to go through this, or even from the neck. If the nerves are coming here, spinal nerves, they do not have to go here into the thoracic cavity, because thoracic cavity is containing the viscera and these nerves are mostly somatic nerves. So, these are the nerves, in fact their parts will come here touching the outer surface of the rib here to enter into your upper limb. So, this is the way, this is the, you say it is the crossroad. There are three passages, they meet in the center, they meet in this area: root of the neck, thoracic inlet and entrance into your upper limb. You can say axilla, means top of the axilla, beginning of your thoracic means the beginning of your this area is very important in the sense that beginning of your upper limb that will go into, you see, beginning of your upper limb means in a canal or in a passage towards the upper limb that guides you into the axilla, means at the top of the axilla is lying here, and right on your medial side there will be a hole through which you can enter into thoracic cavity. This is thoracic inlet, means anybody will leave the axilla can enter over the first rib to go to the thoracic cavity. Two way, either from thoracic cavity over the first rib to enter into the axilla. Because it is not just these two things here, right at this place is the root of the neck also, which is covering inferiorly the thoracic inlet as well as the axilla top here. So, that means if anything is coming from your neck, it has the two options, either to go through vertically through the thoracic inlet into the thoracic cavity, or can come obliquely here, will not enter into the thoracic cavity, will enter into the axilla. Means from neck your approach is very much straight here without even looking at your thoracic cavity into the into the axilla. Like your nerves, all your nerves, they come from the lower part of your neck, enter into the axilla, and during their journey surely it will be their anterior rami and they will make up here the plexuses, call them brachial plexus. Or many viscera, like for example, if the esophagus comes here from the neck, surely it will not go to the axilla, it will go here into the thoracic inlet here, trachea through thoracic inlet here. So, you see, this is what we call here the superior thoracic aperture, you can call it thoracic inlet, but because all these contents which are actually here lying here closer to the upper border of your first rib here, or over the first rib, like the artery, like the vein, like the nerves. So, this area, these neurovascular bundles can be compressed. If the neurovascular bundles are compressed here, if the nerves are compressed, you will have a motor and sensory alteration or losses in your upper limb. If the subclavian artery is compressed here, so axillary artery will not send the blood here to your upper limb, you will have ischemic pain. Or if your axillary vein or the subclavian vein is compressed here, you will have accumulation of the fluid in your arms and your upper limbs here, you say edema will take place. So, all these symptoms and signs will actually take place together because of the compression of all these three structures. So, due to certain reasons at this spot, this is called the syndrome, because it is happening at the thoracic inlet. So, we should have actually called it the thoracic inlet syndrome, but clinicians call them thoracic outlet syndrome. Though anatomically you do not call it outlet, but clinically its name is the thoracic outlet syndrome. So, there is a big confusion between is it inlet or outlet here. Syndrome point of view, it is thoracic outlet syndrome, but anatomically you can call it a thoracic inlet, but do not call it thoracic inlet. Get this confusion being erased from here, you will call it simply superior thoracic aperture. So, these are the boundaries of the superior thoracic aperture, and very important will be some areas which are related to this area, you see that area. And then is the inferior thoracic aperture. You can call it thoracic outlet. No, do not call it thoracic outlet, you simply call them inferior thoracic aperture, because outlet syndrome already you have seen, superior border of manubrium sternum, and then is the costal cartilage, rib, and then your thoracic vertebra. So, this was actually your thoracic upper thoracic aperture, but here the compressions, anything which will be, this is called thoracic outlet syndrome, and here you know that is your neck. But this is actually your abdomen, and if you are actually marking the inferior thoracic aperture is formed here by the tip of the coccyx, I said tip of the, I beg your pardon, this is called the tip of the xiphoid process, and then is the costal cartilage, it is costal cartilage number 7, 8th, because 8th is connected to the 7th, 9th is connected to the 8th, and 10th, because 10th is connected to the 9th. And this is the tip of the 10th costal cartilage, this is the tip of the 9th costal cartilage. And if you are actually watching this, but you will not stop here, because you know that here is the another rib also, whose tip is because a floating rib. So, you can feel its tip also, and then there will be the tip of the 12th, you will be touching now the inferior border of the 11th, and then you are touching the tip of the 12th, and then inferior border of the 12th until you reach to the inferior border of the 12th thoracic vertebra. So, all this one which you are actually feeling here, this all this bony markings, these are called the costal margin, and these costal margin which are feeling in front, this will be actually going on the back side also, we are touching the inferior border of the 12th thoracic vertebra, and this you will call it the inferior thoracic aperture. But you know that all these bones which you are touching, the vertebral column on the back side and the ribs from two sides here and the xiphoid process here. So, if you are actually putting your hand between them, your hand will actually going above in the thoracic cavity, below in the abdominal cavity. And here this hole is not open as such, because there is a partition like a dome here, muscular partition, that is called the diaphragm. So, if anything will actually come from thoracic cavity, will penetrate the diaphragm to come into the abdominal cavity, or from abdominal cavity back into the thoracic cavity through the diaphragm. So, they will have to penetrate and make the holes through the diaphragm. Now, there is one topic that is called a cervical rib. We do not have cervical rib basically, but in some people you see less than 1% of the humans, there is another rib other than these 12 normal ribs. That rib is called the cervical rib, because this rib takes origin from the anterior tubercle of the transverse process of last cervical, that is the 7th cervical vertebra. So, if it is here, you see that thoracic vertebra, this is your first rib. So, this will be your first thoracic vertebra. So, in this cervical vertebra, from here the rib comes. And this is the rib. For example, if the rib comes from the transverse process, anterior tubercle of the transverse process of 7th cervical vertebra, this rib, sometimes the anterior end of this rib is free. Sometimes even this rib, cervical ribs anterior end through a fibrous band is connected here with the first cervical first rib, and sometimes it articulates even. So, you see here, this is the cervical rib which is, and because from cervical vertebrae is coming a scalenus anterior muscle. So, this rib actually looks like this, you see this is black color is the rib. So, this rib, its anterior end can be even free, or it can be connected to the upper surface of the fibrous band, through a fibrous band to the first cervical vertebra, even sometimes it can have even articulation also. So, you can imagine that if this rib is here, so all the structures which I am actually showing you, they will pass over, like the subclavian artery will pass over, subclavian vein will pass over, the structures which are coming from above, like they will here. Okay, they are above that. But because the muscles which are coming from, you see, muscles which are coming from the cervical vertebrae, if they are passing over them to be inserted here to your rib, or the first rib, so that means these all structures will be sandwiched between the muscle above and the cervical rib below. So, they are sandwiched here, you see this is here again. you see these structures will be sandwiched, means cervical rib below and this muscle above. In between you see artery is sandwiched, the vein will be there also and the nerves passing through that. So, if there is any movement of this cervical rib, you see these all structures will be compressed. If these all structures will be compressed here, see this is here, the nerves are passing over the rib, and if the muscle is passing over the nerves, so this nerves will be compressed between the rib below and the muscle above. So, you see that will be compressed here. If they are compressed means if you are making your ribs, you see lifting your arm up here, so the ribs will be moved up and they will be compressed, and compressed means there will be an angulation of the artery also. The artery will be, blood supply will be compromised to upper limb, pain will be there, the vein as well and the nerves also. And because nerves, you see that these are the nerves which are coming from the lower part of your cervical nerves, and lower part you see 4 cervical nerves and the first thoracic, they join together to form their anterior cervical brachial plexus, and the brachial plexus basically enters into your where, you see it can enter, either it can go into the thoracic cavity or can pass over the first rib to go into your axilla. And when it enters into the axilla, it forms basically 3 trunks. This is called its a lower trunk, and lower trunk is the most commonly compressed, and lower trunk is in fact supplying the skin to the inner aspect or the medial aspect of your arm or the forearm and the medial border of your hand, as well as it will give most of the supply to all the muscles usually except some, usually the muscles of the short hand of short muscles of your hand here. So, gripping, all these things are depending on this here. So, that means if you are making some grip, you see the grip will be weaker, even sensation will be altered, pain will be there, edema is there. This is all together is called cervical rib syndrome, or you can call it thoracic outlet syndrome. See all these things here, artery, the vein, the nerves. Now, before finishing this, one more thing that I should tell you here is like a funny fact, that if you are seeing your vertebral column, if you are looking at your vertebral column, in between vertebrae you know already there is a intervertebral discs. So, you have got intervertebral disc here, we have this here also, here as well, here also. This intervertebral disc, we have 23 intervertebral discs between your 30 vertebrae. Some 1/3 of your total length of the spine is comprised of, is by virtue of these intervertebral discs. And when you are going for work and you will leave your bed in the morning, you see this all intervertebral discs which are present there. When you start working and you start walking, due to the weight now, due to the compression over them, throughout the entire day work, some of the water which has been actually grabbed by these intervertebral discs, it is leaked here. So, these intervertebral discs which were previously little bulging, by the time you go to bed at night, they have become little thinner now, means it will be little thinner. So, previously due to water, because you have slept throughout the night here, so they have gathered water and they have become bulged. But when you are actually working in the morning till night, you are working whole day, you see that they will become now thinner. Means if they become thinner, so your spine total, its length will be reduced. When this length is reduced, means by the time you are going for sleep at night, after whole work throughout the day, your intervertebral disc, due to the compression from above, they have become thinned. Means your total length of your vertebral column has become reduced. They say that when you are going to bed, almost you have lost almost 1% of your total height you have lost. And when you sleep now your compression is gone, and your intervertebral discs are now gaining more through osmosis, they are gaining more water and they get bulged again, and when you wake up in the morning, you have regained your 1% height here. So, that means when you will actually leave your bed, you are 1% longer or taller than when you have actually gone into the bed at night here. This was your class today, and this is about the thoracic cage, not the walls full, because walls means now you will actually add some more structures. This is called the intercostal apparatus, intercostal muscles, arteries, veins, lymphatics and nerves, and then some other structures like skin, superficial fascia from outside, and two more structures inside the cavity also. This is called the endothoracic fascia and the parietal pleura, means two things inside, two things outside, and in between will be the ribs, and surely there will be spaces, and spaces have to be filled with the muscles and neurovascular bundles. If you have done this plus this which we have seen here, the thoracic cage means a bony structure and that soft tissue, together you call it the, and surely suprapleural membrane above and diaphragm below, a cavity has been created inside, and that cavity will be filled with the viscera, and in that viscera almost 100% cavity, you will actually divide them into the 50% on one side. You see, if for example this is here, you are actually watching like this, diaphragm here, suprapleural membranes here, and if you divide them into the two, cavity has been divided into the 50% here and 50% here. Out of this 50%, 10% you leave it vacant and 10% adjacent on the other side you leave it vacant. Remaining, this remaining entirely inferiorly bounded by lungs, from all sides by the ribs, behind and above by suprapleural membrane. This structure which occupies this whole 40% on this side and similarly 40% on this side. Of the cavities, 80% has been occupied by this pair. This pair is called the lungs. And what you have left in the middle now will now be available for occupation of all the things now, all the viscera, including even heart, and even all these viscera will be occupied by this 20% central partition, partition between two lungs, median partition, and that median partition is called the mediastinum. Means if you have got 100 structures in the thoracic cavity, for example, you have 2 lungs and 98 structures will be mediastinal structures. So, inside the cavity you have got 2 things here. So, when you will actually enter after thoracic walls, you will have to do here the things like the lungs number 1, the heart number 2, and mediastinum and all other structures number 3. These are the 3 major subdivisions of the thorax. After thoracic walls is the 4th subdivision, along with their clinicals, along with their MCQs, along with their clinical cases. If you are actually doing them together, the thorax will be very, very easy for you. This is our class today.